Welcome to the Systems for Action Research and Progress webinar series. If you haven't joined us in the past, my name is Carrington Lott, and I am the Deputy Director at Systems for Action, which is a national research program office funded by the Robert Wood Johnson Foundation. Our Systems for Action program office is housed at the Colorado School of Public Health in the Health Systems Management and Policy Department. And this is a series that we do at Systems for Action on a generally bi-weekly basis where we have grantees that are funded through our program come and present at different points in their research projects to provide some real-time rapid updates on what they're learning and what they're experiencing and what barriers and successes that they have so that our audience can learn alongside our researchers. And I guess I should take a step back to say that one of the main activities we do at Systems for Action is to fund research through typically annual funding opportunities that we release. And every single funding opportunity that we put out there always has one thing in common, which is that we're funding innovative system alignment ideas that align delivery and financing systems across the medical, public health, and social service sectors. So today you're going to be hearing from one of our teams at the University of California, San Francisco, and you're going to be hearing them talk about their evaluation of the effectiveness of California's CalAIM Medicaid reimbursement program. And this is their second or third time presenting in this series. So they are going to have some great updates. And if you've joined us in the past, for one of these presentations from this particular team, then you are going to hear some great updates. Can I go to the next screen, Caroline? Thank you so much. Okay, a couple of housekeeping items before I hand it over to the team to present their research findings. We are here at the welcome, and then you'll hear from the team and their presentation that they have, and then they've invited someone to provide some commentary, and I'm going to allow the team to introduce everyone in just a moment, but we'll have about 5 to 10 minutes for commentary, and they're going to speak to just the importance of this project from a community perspective, and then we always save time at the end of these presentations for Q&A, so if you have any questions that come up at any point during the presentation today, please locate the Q&A box at the bottom of your screen, and we will make sure to save time to address those questions to the team. And as always, this presentation is recorded, so we will send out the recording as well as the slides that are covered during today's session. So thank you so much for joining. I am going to step back and allow Caroline to hop on and introduce her team and walk us through what's going on with their project.
Great. Thank you so much, Carrington. And hello, everybody. It is so nice to be back again on this forum to share updates about our Systems for Action research project. This slide shows you the folks who've been part of the team for this project. On the left side, the Siren UCSF team. So we're located at the University of California, San Francisco, within the Social Interventions Research and Evaluation Network, or Siren. And then we partnered for this project with folks at 211 San Diego and also at Health Leads. Unfortunately, all the individuals on this slide who started the project with us have, as of pretty recently, moved on to other positions, but we have someone else from 211 who will be speaking as a commentator at the end of or after our presentation. You will be hearing today from myself, Caroline Fichtenberg. I'm a co-director of the Social Interventions Research and Evaluation Network at UCSF, and also from Rohan Rastogi, who's an internal medicine physician at San Francisco General Hospital, and also just finished his clinical fellowship with the National Clinician Scholars Program, also at UCSF. And then the best part of this will be that you will get to hear from two commentators. One is Ajira Darch, who is a doula and involved in a number of birth justice work, as you can see, an impressive amount, and also member of our Racial Health Equity Advisory Group for this project. And then you'll also hear from Joanna Oboza, who's the Director of Community Care Coordination at 211 San Diego. Again, 211 San Diego was a partner with us on this project. Great. So let's get started. So what I'm going to be talking to you today is about one part of our project that is looking at the question of how is racial health equity being advanced through CalAIM implementation. And I'm going to tell you a little bit more about what CalAIM is for those of you who don't yet know, so that this makes sense. So CalAIM is a Medicaid reform program that began in January 2022. And it stands for California Advancing and Innovating Medi-Cal. And Medi-Cal is California's Medicare program. The goals of CalAIM are to implement a whole person approach and address social drivers of health, to improve quality outcomes, reduce health disparities, and drive system transformation, and to create a consistent, efficient, and seamless Medi-Cal system. And the last point around the seamlessness involves also including a number of organizations that hadn't previously been part of the Medi-Cal system, specifically organizations providing social services. And I'm going to tell you more about that next. So there are two key features of CalAIM related to this, to addressing the social drivers, reducing health inequities, and creating a more seamless integrated system of care. And one is something called enhanced care management. So this is a new benefit that is part of Medi-Cal for a certain set of specific populations that provides intensive care management for medical and social services. And this is intended for high need, high cost members so that they have that one person that is really helping them coordinate their health care, coordinates the access to social services, etc. Second, CalAIM introduced a set of new services that Medi-Cal beneficiaries could have access to if their plans wanted to offer them. And these are 14 non-medical services. Actually, now there's 15 because one was added this year. And these, I'll show you on a next slide what they involve specifically, but there's a lot of things related to supporting individuals who are homeless to get stable housing. There's medically tailored nutrition. There are other services for transitioning back to community settings from more intense healthcare settings, and asthma services, and a few other things. So the key about this is that the way that these services were meant to be delivered to Medi-Cal members was through Medicaid managed care plans, contracting with healthcare and non-medical organizations to provide these services. And so our project overall was to kind of look at the implementation of these two elements of CalAIM to see how well this is happening. In particular, how well are these different parts of systems, the healthcare system and these non-medical organizations, how well are they integrating to provide seamless care for Medi-Cal members? And in this presentation, I'm going to focus just on one of the questions that we looked at in our project, which is a focus on this goal that CalAIM has to reduce health disparities. We were specifically interested in how is racial health equity being advanced through CalAIM implementation. So that is what we're going to share. Some initial results on this question is what we're going to share today. Really quickly, our research activities for the project as overall involved a survey of social service organizations that we presented the results on last year. And some of that is about to get published also. A set of local case studies, and I'm going to be talking to you about those today. And then a backbone organization community of practice that 211 San Diego led. So for these local case studies, we wanted to understand a whole range of things about implementation, but we had to narrow our focus just because even within these two programs, ECM and community supports, there's a lot going on. So we didn't want to kind of try to bite off too much. So we decided to focus on services being provided to individuals experiencing homelessness, which is a big, one of the major populations receiving services through CalAIM. And then secondarily, we decided to focus just on housing-related community supports. Here you see the whole list, and we focus just on those 5 in that orange box. So housing transition navigation services, which means helping people access, like people who are homeless, get into more stable housing situations. Housing deposits, which pays first month's rent and move-in fees and furniture for people who are moving into a new space. Housing tenancy and sustaining services, which supports individuals in staying housed once they have become, and then short-term post-hospitalization housing and recuperative care that are both forms of providing a place for individuals who are coming out of the hospital who don't have a stable home to get better after a hospitalization. So those are the services that we focused on. And for our case studies, California is a really big state. We have 56 counties. And we decided to focus on 3 counties for these case studies. We picked 3 counties that all have high rates of homelessness, but provided a slightly different context. So Humboldt in the north is a very rural county, not very populated, but a lot of homelessness nonetheless. Santa Cruz is just south of the San Francisco Silicon Valley area, and it has an urban center in Santa Cruz, but also a lot of remote areas, and also a big problem with homelessness. And then finally, Los Angeles, which is one of the largest, I think, second largest city in the nation, and a very urban environment. So that way we have some varieties of environments to look at. We then reached out to a number of organizations in 3 categories. One, community-based organizations or agencies providing services to homeless individuals. So they would be providing either enhanced care management or one of those 5 housing supports that I showed you on the previous slide. And we ended up being able to reach 20 and interview 25 organizations spread out across these 3 counties. We also spoke to 7 Medicaid managed care plans that were working in these 3 counties, and 6 technical assistance providers. These are organizations that are either hired by the state to help run these collaboratives to help organizations participate in CalAIM, or they're providing direct TA to organizations that want to participate. So we ended up talking to 7 Medicaid managed care plans and 6 technical assistance providers. And we did all these interviews from March through October of last year. And that was the 3rd year of implementation of CalAIM, like midway through the 3rd year of implementation. A little bit more detail about the homeless service providers that we talked to. So there were 21 organizations that were providing either community supports and enhanced care management. Several were doing both. These were organizations that were providing recuperative care, housing navigation and housing deposits, permanent supportive housing. There were also some behavioral health organizations that were providing ECM to homeless individuals. And then there were organizations that provided a variety of services. We did manage to talk to 4 organizations who are not providing either enhanced care management or community supports, because we wanted to get their perspectives as well. And we were hoping to be able to talk to a number of culturally specific organizations. So these are organizations that specifically focus on servicing a culturally or language or ethnic specific population. And we were hoping to talk to more, but found that in the housing space, there weren't that many that were very specific to a specific culture, language, or ethnic group. So that is who we talked to. And this is what we asked them. One of the goals of CalAIM on paper is to reduce racial health inequities. do you think that CalAIM is effectively doing that? And why or why not? We also asked, how is your organization thinking about racial health equity as part of CalAIM implementation? So now I'm going to share what we heard. I'm going to be sharing information about what we heard from the service providers, so these CBOs or county agencies that are providing services. And then Rohan will talk about the plans and the technical assistance organizations. So overall, what we heard, interviewees really did not have that much to say about racial health equity. And this was pretty disappointing. Generally, when we asked this question, it kind of took them, they were a little off guard or off, like, they were like, oh, well, they didn't have that much to say about it. And it didn't feel like they had thought about it that much. They kind of had to like sit there and think and be like, well, I guess this is kind of how we're thinking about it, which was a little bit disappointing and indicated to us that, that this was clearly not a huge priority that was in terms of these organizations. So that was the first thing that we heard. Another thing that we heard from these service providers is that they felt that by serving those who were underserved, because the underserved are disproportionately people who are marginalized by racism and other factors, they would be kind of automatically helping address racial equity. So for example, I do think that given that homelessness is so racialized, that just even by accident almost, even without making that a priority, connecting all our clients to enhanced care management, for example, will help ensure that our clients who are disproportionately part of marginalized races have an easier time accessing healthcare services. And I think the same goes for the other community supports as well. And so we heard several organizations kind of making this kind of a point. Indeed, I had another quote there. The vast majority of folks that we serve as an agency, and certainly we're seeing through CalAIM, as well as some of the most underserved, under-resourced, both communities and clients. Sorry, the vast majority of folks that we serve are some of the most underserved, under-resourced, both communities and clients. So my hope is that because that's who we actually already serve, that we're making a difference. So it was kind of like, after thinking about it a little bit, they were like, well, we're kind of doing it naturally just by doing what we do. Another thing we heard is several organizations saying, well, the way that we're ensuring that we're addressing health equity is because we're treating everyone the same. So somebody said that we just try to treat everybody the same. Somebody said something like, most of our clients are white, older males, but I do think that when the opportunity is there, which I think they meant when we have clients that are not white, we definitely are equitable. So we treat them the same, I think is what they were trying to say there. Fourth, people mentioned that they have diverse staff, and so they're trying to ensure that they have cultural concordance, et cetera. So I think impacting racial equity is more so driven by overarching, what is the agency doing to prioritize that? And around ensuring training for staff and the diversity of our workforce, both at the provider level and at the agency level. And so this homeless service provider did recognize that, how much are you prioritizing is really important. And then they felt that the other thing was having diversity on staff and staff that are trained. And another person mentioned something similar. So it's part of our DEI to be recruiting and retaining anyone who's bilingual and bicultural. And another organization mentioned something similar. All our leadership at Black and Brown are women, and so we just do our best. So again, this idea that like the cultural and language concordance and diversity of staff being a key element. Another element that came up is people saying, well, the managed care plans really haven't been focusing on this. So there hasn't been too much guidance from the managed care plans as far as how they want us to capture that information and to track it. And the other person on the review saying, yeah, I don't think it's really felt like a strong priority. So this organization felt like we're not really getting any signals from the plans that this is something we should focus on. Now, there were some more nuanced responses. Um, so one person said equity is about access. And if you don't make the access equitable, then they're not accessing services. So really this focus on the importance of equitable access, although they didn't go into detail about how they were doing this. And then another organization highlighted the importance of culturally and linguistically appropriate services, and also the extent to which the managed care organizations really understand that. So they felt like, again, the managed care plan plays an important role, and it's kind of up to them because they're the ones that are picking the organizations that are providing services. And they need to pick organizations and focus on organizations that are culturally and linguistically appropriate. And then another one that said, I would say if it is successful, it would take take longer than whatever the state is expecting it to take, because this is just really complex. Dismantling structural racism is not going to happen overnight. There needs to be enough exposure of folks that need those services, exposure to agencies like ours. There needs to be the trust built. There needs to be enough infrastructure set up where these services are accessible. So again, somebody else kind of acknowledging the complexity of this and how it's much more than just we treat everybody the same. So in sum, what we heard on racial health equity as part of CalAIM from homeless services providers was that racial equity did not seem like much of a priority for most respondents, which was pretty disappointing to us. Several felt that just by doing what they were doing, serving homeless individuals, they were helping to reduce racial inequities because of the disproportionality experienced by people facing racism that put them at risk for homelessness. Several felt their staff diversity and language cultural concordance were key. Sorry, I don't know why this is out of order. A few felt that treating everyone the same was enough. A little bit more, I think, thinking a little bit more thoughtfully about it. There were folks that brought up the staff diversity and language cultural concordance. And as I mentioned, those others that had more nuanced responses about what's needed in terms of thinking about access and thinking about trust and all those kinds of things. And bottom line is no respondents shared any racial equity plans or goals. None of them said, oh yes, this is what we're doing to ensure that this is really going to be reducing health inequities. It really seemed like something they weren't really focusing on for putting a lot of focus on. Great, I'm going to turn it over now to Rohan, who's going to talk about the managed care plans.
Everybody. So yeah, I'm gonna be sharing some of the results from the managed care plan conversations that we had. We spoke to seven plans. Five of them were participating only at the local level, so in a single county or in a single isolated region, and two were kind of in the multi-county, more general space where they were providing services across California, and some of them were representatives from companies that work in other states as well. And again, the question we asked them was, how are you thinking about racial health equity as a part of CalAIM implementation? So the first, I unfortunately again was that we heard from a lot of managed care plans that this is not really a priority for them. This is particularly disappointing because, we heard from some of the service providers at the community level that they felt like they needed instruction from the managed care plans, and yet we heard from almost a majority of the managed care plans that they hadn't put a ton of thought into it either. So one managed care plan said, I don't know that our organization, and this is again me being fully transparent, I don't know that we've done a great job in really looping health equity into the conversation as a priority. I think that some of our counties naturally are just forced to do it just based on the distribution of members. But we do have a report that looks at who's enrolled by ethnicity, by zip code, so that's helpful. So we actually built that out to really try to honor a level of equity, but I can't say that we're doing any type of training or targeted engagement to really highlight what that looks like for our provider network. Next slide. And echoing what other the service providers at the community level were saying as well, a couple of managed care plans really said the same, that they felt that by serving the underserved and serving those who were more marginalized by systemic racism and therefore had some of these health-related social needs that CalAIM intended to target, they were doing the equity work by default. If you can hit the next slide. Yeah. So I think inherently the program is designed to address health equity, right? Because you're hitting those who are the highest need and by all metrics are doing the worst in many ways. It's not a complete picture. It doesn't solve for healthy children who are getting the vaccines, but I think it's a key component of enhanced care management and community supports. Next slide. I think there was another quote from this. No, okay. Another thing that we saw was that managed care plans were more focused on rural areas, um, felt that the populations of focus that were being designated by the state of California as those who were marginalized or more underserved in a particular area of CalAIM implementation focus didn't match the population at risk within their local context, and they wanted more flexibility on administering the equity related benefits that were um, deemed to be eligible for from the state of California. So a quote that exemplified this, we actually got into a back and forth with the state and their analytics team with our incentive payments program submission, one of the reporting elements that the state had by county. They wanted to look at the number of unhoused Black or African Americans. And so in our county, that's zero. That's zero. And the state didn't like that answer. They got back to us and said, you did this wrong. And we said, no, there's no Black or African American unhoused people in that community that we are aware of on any data element, unless you show us something different. So I think it's really, really, really important that when we talk about health equity or disparities, that we do it with the spirit of the community with which we're talking about. And we don't apply a medium-sized t-shirt to the entire state. So what health disparities and equities look like in rural California from a cultural ethnic makeup is very different than what it looks like in urban suburban areas. It's structural urbanism is what it is. And what happens is those communities get left further and further and further behind because of it. So this is from a quote in a rural area. I have another quote from a county with more of a mixed population. Um, there was a recent rub between leadership on birth equity. So a lot of our providers said, hey, is this just going to be for those populations, referring to the ones that were designated by the state? It's just Black, Alaska Native, Pacific Islander, American Indian. And first we were like, yes, absolutely. That's the intent of birth equity. That's why it's called the birth equity population, because California Department of Public Health says they have the poorest maternal health outcomes. So at our MCP, however, there's a lot of back and forth about this. We actually opened that up to include all racial and ethnic backgrounds. So the compromise is that we'll approve them if they refer them. Next slide. Um, and you know how we previously heard that in the service organizations at the community level, those organizations often felt that that was a role of the managed care plans in designating how to approach equity from a racial standpoint. On the flip side, I think the managed care plans frequently were saying that they felt like there was a lot of power at the local level in advancing racial health equity, and particularly in contracting with culturally specific service organizations. So a couple quotes on this. If we can engage some of those very local organizations, they're the ones that are going to know, the population, have people on their teams that are probably are reflective of the population that they're serving. For example, we're engaging an organization that's in a local county that does a lot of outreach on tribal lands. Their staff look like the people they're serving, that's their focus. Again, trying to really engage those local community-based organizations that look like folks, know the community context. Next. So summarizing what the managed care plan said, really the main takeaway was that they felt that partnering with local community-based organizations was their primary intervention to advance equity. Next. Some said that equity was not yet a priority. And again, just by serving underserved individuals, that they were helping to reduce racial inequities. And there was a sentiment among rural managed care plans that the populations designated by the state did not accurately reflect the local at-risk populations, and they wanted more flexibility with administering their benefits. Okay, so now I'll move on to talk a little bit more about the interviews that we did with technical assistance providers. And just to remind us what are TA providers, TA providers are organizations that help Medi-Cal managed care plans, community-based providers, and county agencies implement the CalAIM programs effectively. So they're often kind of like an intermediary between all the involved parties of CalAIM implementation to provide technical assistance, meaning that they'll provide data support, provide training, um, help bring in community organizations into the fold, and really assist with kind of troubleshooting and getting people into the program in terms of organization support. And we asked them the same question: how are you thinking about racial health equity as part of Cal implementation? And we spoke with 6 providers regarding racial equity. So one of the salient themes that came out again was this idea of serving the underserved. 4 providers mentioned this. I have a few quotes that exemplify that. So again, just by the nature of serving people with that population focus, you're potentially dealing with some inequities. Another TA provider said having this focus on reaching out to providers in the more underserved part of our county, making sure that they are going through the process of becoming contracted, we think will naturally just increase availability and access to services to this population. And so I would say that has been a focus in terms of how we implement racial health equity. For many of our providers, the most vulnerable folks are the folks who are presented in front of them. If they're the provider that ends up being tasked to support someone who's prioritized for supportive housing coming out of a coordinated entry program. Next. I think there was an acknowledgement in amongst the TA providers that even though in I think the case for a lot of the TA providers, they would consider equity and advancing racial health equity in particular to have been a priority, that they weren't doing enough, or they could be doing even more. So this quote actually, acknowledged that maybe that idea of just seeing the most vulnerable people was somewhat surface level, insufficient. It said this health equity work in CalAIM could be done better because we're almost in a sense taking the vulnerable populations, but then how do you really ensure equity across that? So I think it's really been about elevating the conversation to understand what that looks like in a CalAIM scenario. I do think we could be doing a better job of intentionally addressing health equity, but those are some of the ways that we've begun. Next. And again, about doing more, I do think we could be doing a better job of intentionally addressing health equity. But in the case of this particular TA provider, and I'll talk about this more, they said we've started by having a diverse and inclusive team. And those are some of the ways that we've begun to address racial health equity. One of the interesting themes that arose from these TA providers was that in their pursuit of racial health equity, as they were thinking about how to advance it, they really felt like they needed more data at the local level to help guide their efforts. So a couple quotes on that. It'd be great to be able to see who is being supported by Cal Community Supports in our county, and does it look like the folks who are experiencing homelessness in our county? I haven't seen those numbers, and I haven't seen any numbers around who are the key community supports providers. I imagine that the plan is supposed to be reporting this to the state, but I don't know if there's anyone at the state who's paying attention. I feel like I don't know if it can happen at the county level, if there's a feedback loop, if there isn't a feedback loop, but I don't think there's a good feedback loop in general with Cal and community supports. Um, Another theme that came through was that the TA providers have this interesting role of actually being able to look at their local or regional context and try to engage organizations at the community level into CalAIM and assist them with starting up their CalAIM program. And so one of the ways in which they were advancing equity was by trying to outreach to organizations that particularly serve minoritized populations and not only include them, but then assist them in becoming successful and engaged members of CalAIM. And so one TA provider said, more BIPOC-led agencies started out by not having CalAIM contracts. And honestly, many were not included in early implementation. Um, with their continuative care or with anything that was led by the DHCS, the Department of Healthcare Services, or the collaborative planning and implementation. People said they didn't know about it or they weren't invited. So this quote was kind of expressing a sentiment that we saw amongst TA providers that they felt like minority serving organizations were left out of CalAIM program to begin with, or were less likely to be included because of other factors. And so they kind of had that in mind and were trying to do something about it. Next. Where I feel CalAIM might not be reaching its impact is when its goal is to reach more Black, Indigenous populations. And I don't think the resources are equitably being distributed to these organizations. If you look at the cited grants, a lot of them are multimillionaire entities and are not necessarily going to smaller community-based organizations. In round 1A and 1B, hundreds of millions of dollars distributed, not a single one to a tribal entity, a tribal nonprofit, a tribal government, or an Indian health center. So this quote is referring to um, financial support that was provided by the Department of Healthcare Services for startup funding to community-based organizations um, to help them launch their CalAIM program, and was saying that they weren't included in financial support at the beginning of implementation. Next. And so this is kind of talking about how those TA providers then went on to try to address this issue that they identified. So they said we wanted to target agencies that were led by leadership teams that were made up of people who identified as Black, Indigenous, or persons of color, either the executive director or the majority of their executive team. And we also asked about how people with lived experience of homelessness were included in decision making, not only just on a board. So summarizing what we saw with the technical assistant providers, mainly, there was a sentiment again that TA providers felt that just by serving underserved individuals, they were helping to reduce racial inequities, which is a theme that was echoed throughout the participants that we talked to. Several felt that they had just begun to scratch the surface of advancing equity. They acknowledged that, they had thoughts on it, they were trying to do initial steps towards it, but there was really a lot more to be done. One of the ways that they hoped to do more was by reviewing local data on equities, and then tailoring interventions um, iteratively to the populations that initially had greatest need or continued to have greatest need despite their initial efforts. And really, one of the ways that the TA providers felt that they could have the most impact was by including in the fold of CalAIM organizations that were minority-led, community-embedded, minority serving. And they felt that this hadn't been done by the state in the initial implementation of CalAIM, or that the initial efforts from the state just didn't reach those local minority serving organizations, and that this was a way in which TA assistance providers could really have an impact. And that this was one of the ways in which they were uh, trying to have an impact.
Great. Thank you, Rohan. I'll just share some conclusions based on this. Again, this is our initial analysis. But overall, from talking to service providers in the homeless services space, Medicaid managed care plans, and technical assistance providers in 3 counties, there was a disappointing lack of focus on racial equity across all 3 groups in some ways, although TA assistance providers seem to be thinking about it the most and doing the most about it. Many felt that just by serving the homeless, they were disproportionately helping groups harmed by racism, which is true, but also not enough for really reducing health inequities. Some felt that treating everyone the same was the main way that they were doing it, which felt insufficient to us. Some recognize the importance of removing obstacles preventing small, culturally competent providers from participating, as Rohan just mentioned, with the technical assistance providers and somewhat with the plans. And some final thoughts that come to us from reviewing this is that it feels like racial equity needs to be built from the beginning. It can't be an afterthought. And that DHCS should be holding plans accountable for reducing racial inequities and doing more to support participation of small, culturally competent service providers who clearly are facing obstacles. And the plans should also be focusing more on racial equity. And finally, that there should be more technical assistance to plans and service providers about how to provide services in ways that reduce racial inequities, how to really provide those services in culturally competent ways that address all the barriers that racism creates. I do want to share a few limitations. We only talk to homeless service providers, and really we're only talking about those kinds of providers and those kind of services. So CalAIM implementation, when it's talking about food or other kinds of services, may be different. It was only limited to 3 counties. So again, not the whole state at all. And our sample was definitely skewed towards organizations that were already participating because that was much easier to identify. And we only spoke to 3 culturally specific providers, but all 3 of them were facing much more barriers than the other organizations. So that is our presentation. We'd like now to turn the mic over to our commentators. So first we have Ajira Darch, who again is a member of our Racial Health Equity Advisory Committee. Ajira, I will turn it over to you.
Hello, everybody. Thank you so much for presenting that. It was interesting to see it again in one concise presentation. And I was definitely struck by some of the quotes that have stayed with me since I first heard them. So I'll say that I was not at all surprised that the community-based organizations tended to make remarks that aligned with my thinking around how racial health equity could be addressed, or even how it could be prioritized. And I was not surprised that the managed care plans didn't have much more beyond like, oh, we're helping everyone. Surely that's making a difference. I think that's been my experience for the most part in the space, is just a lack of awareness or even understanding, but also some assumptions, I think, that go into these kinds of recommendations, right? I think a question I kept bringing up to Caroline and the team is what is CalAIM, how is CalAIM explaining or teaching about health equity and about racism and about how it impacts everyone? Because if you are making these kinds of recommendations, assuming that everybody has the same understanding, even, or any understanding of what health equity is, of what racial health equity is, of what racism is, or any other social driver, or how it impacts people in real terms, then I think we see gaps like this, where there's a lot of assumptions around, oh, we're serving people who are already marginalized, surely just by the wonders of the world, I guess, health equity is somehow going to be achieved because we're treating everyone the same. To me, that just signals a profound misunderstanding or lack of knowledge around what racism is, how it impacts people, how it impacts all of us, and then how or why even health equity is something that needs to be prioritized, and how it can be prioritized. There was another thing I think that also stood out to me, which was this sort of idea of like, oh, we don't have Black people here, so that's not a problem, so we can't do like racial health equity. Again, that to me signals a profound misunderstanding about it, because one, a rising tide lifts all boats. And we know through our work, certainly as birth workers, that when we prioritize the most marginalized, the most harmed, the most vulnerable amongst us, that improves outcomes for everyone. So, it's a little disheartening to hear people who are working in the medical space, some of them at least, right, who are working in the care space, not be thinking about how, triage is very it's something that's done everywhere, and it's done to do exactly what I described, to prioritize those who are most harmed and improve outcomes for everyone. And so why this is such a stumbling block is very telling, I think. I was also very, very disturbed to hear that quote from one of the TAs who talked about millions being dispersed and not a single tribal or Native American organization was awarded any of those funds. I think that's also something very disturbing about the landscape we've created in terms of how we care for people in need, and folks who are dealing with houselessness. or being unhoused, you know, believing that if you just treat everyone the same, that somehow that will magically even the playing field is alarming. So yeah, I'm glad this information is out there. I hope that people who needed to hear it in this way are able to receive it and think about some changes that could be made. And I would definitely love to see a little more conversation around what racism is, how it impacts all of us, what racial equity could look like, what health equity could look like, and why we're prioritizing it at this time. Thank you.
Thank you, Ajira. That was really helpful. Um, I would love to turn it over now to Joanna, who works at 211 San Diego and has been leading efforts to implement CalAIM, I think in San Diego with 211 San Diego. So Joanna, the floor is yours.
Yes, thank you, Caroline. Yeah, really, really fascinating information. Can't say that I'm surprised by any of the responses from the different stakeholders within this space. I think just really quickly, just to kind of level set with how CalAIM is functioning here in San Diego County, for those of you who may not know. So San Diego County has 4 Medi-Cal managed care plans, which provide benefits and services to the Medi-Cal population here in San Diego County. This has definitely posed some challenges in terms of access to these services because there aren't streamlined, specific ways for people and individuals to learn about CalAIM services and then also to be referred and connected to CalAIM services. The managed care plans, each managed care plan has a different process, a different referral pathway. So it's definitely made it difficult for individuals to really understand how to access these services. So something that we early on recognized at 211 San Diego and something that we've tried to implement to really try to improve that overall access to these services, as one of the commentators in the presentation shared, equity is also about access, is about how easily people are able to access to these services that are targeted for the underserved populations. And that's been really, really one of the biggest challenges that we've identified here at 211, just in terms of individuals trying to reach out to their managed care plans and learn about these services and be able to be seamlessly connected to these services, unfortunately, is not happening. Oftentimes, we're hearing from clients that they're calling their managed care plans and they're being turned away because they're not using the right language when they're trying to access a specific community support program, for example. For example, if someone's sharing that they're at risk of eviction or they need rental assistance, some managed care plans off the bat will say that's not something that we can assist you with. Please call 211, and they get rerouted back to us. So what we've been doing here at 211, which I think has been helpful for the community, is really trying to be almost that air traffic control for the community related to CalAIM programs. So really embedding that within our call center of individuals who are calling in for any social need that they have, from food to transportation to accessing a primary care doctor to ADL needs. We use that as an opportunity to screen that individual for CalAIM and then essentially facilitate a closed loop referral for that individual and really advocate for as many individuals that we have that we're able to in connecting to those services. So if we get a client calling back in saying, I tried accessing, my managed care plan for this service, but they turned us away, then we would advocate for that member, complete a referral form, and then facilitate that closed loop referral, give the managed care plan the information that they need to determine that eligibility. And we found this to be really, really helpful for the community and being that almost that advocate for these individuals and connecting to these services. So that's something that I think has worked really well in really just trying to provide that one streamlined pathway for these individuals. So instead of each Medi-Cal member having to remember which managed care plan they're enrolled with and what that process is for that managed care plan. Instead, they call 211, which is an easy to remember number, and they can ask and then be connected to those services, and that outcome be facilitated for that individual. So that's been one thing that I wanted to highlight as something that's been something that we identified as definitely a challenge in terms of access, and one of the kind of solutions that we implemented within our community. And another thing that I wanted to highlight, which was definitely demonstrated in a lot of the responses from today's presentation. One of the challenges with engaging some of these local organizations is one that I think we need to definitely work towards better solutions, because for those of you who are not in CalAIM, the requirements to provide these services are very, very intensive. It requires a lot of data. It requires a lot of documentation. It requires a lot of various different assessments and screenings. It requires a lot of information, a lot of tracking of information, and then also billing this information through kind of the Medicaid system, which for a lot of the local organizations that want to be providing these services don't have the capacity to do. So here at 211 San Diego, we are, for example, an enhanced care management service provider, and we're a large organization. We are anywhere from 300 to 400 individuals. You know, I have an informatics team that I can leverage. I have a finance team that I can leverage. I have lots of different, subject matter experts within the organization that help facilitate CalAIM programs. For some of these smaller organizations, I've worked at a very small refugee resettlement organization before I came to 211. They don't have the infrastructure they don't have, customizable client record management systems where they can document in the specific way that a managed care plan wants that organization to document certain things or complete specific assessments. And then also with the billing, I think the billing has been something that has been a huge deterrent for a lot of smaller nonprofits, because it does require this kind of new way of drawing down those dollars, which from our own experience has been an extraordinary administrative burden. So what to say, all that to say is that I think one of the opportunities for us to consider, and something that's been working really well here in San Diego County, has been something called the hub model, which is essentially a structure in which a larger organization that has kind of that infrastructure to do all the administrative pieces of these contracts, that larger entity subcontracts with smaller organizations, more local organizations, where they provide the technical assistance, they provide the training, they do the performance monitoring, they help with staffing. So the larger entity subcontracts with these smaller entities, who those smaller entities can then focus their efforts on being in the community, identifying those individuals who are eligible for these services and connecting them to those services, instead of being bogged down by all the administrative pieces of these contracts. So in San Diego County, for example, there's one organization called San Diego Wellness Collaborative, who has really been leading the charge in that model. And I believe they currently have 8 subcontractors, and they're actually looking to expand to about 20 additional subcontractors by the end of next year, which will then allow for them to provide more culturally appropriate services throughout the county, and having those organizations really be focusing on the work that truly matters, which is engaging with those members who need these services and connecting them to all of those critical services. So that's just something that I think that model is being leveraged across different counties, and the counties who have been leveraging that model have been having, I think, better outcomes and strong and better successes with these services, by kind of distributing those efforts among different subcontractors, instead of, like for us here at 211, it's, a lot of the administrative pieces that, as the director of the program, it's a lot of like having to do reporting and data collection, data analysis, instead of kind of taking us to the next level of improved outcomes, improved, equity efforts, which are so critical. But because there's such intensive administration to these contracts, sometimes just maybe doesn't discourage us, but doesn't give us the opportunity to really move forward in some of those other very specific efforts. So that's all that I would have to share. But really appreciate this research. I think it's really, really critical. And I do hope that, you know, it gets to all of the different entities that need to hear this information, and that, you know, as communities, we can really identify, you know, what are our best ways forward, and, you know, what are the true outcomes that we're all driving towards, and really being able to hold each other accountable to those outcomes.
Thanks
Thank
so much, Joanna. I'll turn it over, I think, to Carrington for questions.
I know we only have 4 minutes and we have a couple of questions that have been entered, but if anyone else has any questions, please don't let that deter you from putting yours in the Q&A box. If we have some leftover questions that come in that we don't have time to address, we always give that to the research team to respond to, and we send that along in our email follow-up. So please put any questions that you have in the chat. I'm going to start off with a comment, and I guess, you know, you said multiple times, like, these weren't the findings that we were hoping to have, but I think the findings that you did have are still very important and address a lot of gaps that are happening in the implementation of this. And so I think they're fascinating findings, not uplifting findings, but I think you're going to have a lot of great reports to give back on ways to improve the system, which is good. And then Caroline, you said something earlier about being intentional from the start when you're recruiting the types of organizations that are participating, and I really appreciated that. And I think it sort of portrays how systemic racism that's embedded within these systems is just continually perpetuated, because even though you're not intentionally leaving out organizations, you're also not intentionally recruiting organizations that are serving the BIPOC communities. And so I think that really struck with me, and I appreciated you saying that and pointing that out. And then I'm going to use one question that came into the chat and kind of build on that. But Johnny Williams put the first question in the Q&A, and that question is, would you find that CBOs implementing CalAIM services do not understand what racial health equity is as a term? And I sort of had the same thought, because it sounded like a lot of the organizations were conflating racial equity with equality with the types of services that they were providing. And so I'm wondering if you came across that issue. And then also, it sounded like a lot of the CBOs that you interviewed had the point of view of seeing the managed care plans as the leaders here and kind of looking to them for guidance. But then hearing Rohan speak to the managed care plans that you spoke with, a lot of them weren't being intentional about it either. And so I'm just wondering about this, like, intentionality around goal setting and goal attainment, and like, who is in charge. And I think this comes up so often in systems alignment research when you bring all these partners together, because everyone thinks someone else is in charge of doing this, and who's really in charge of making these decisions. So I wonder if you could speak to the racial health equity piece, and then also just from your point of view, like, who should be setting these goals and guidelines around racial health equity and what that means and what it looks like in the system.
Great questions, Carrington. And I'll try to answer them really quickly. I do agree with you. I think that people, and I think this goes to what Ajira was saying, that people don't really understand what equity means, what racial equity means, or any kind of equity. As you said, that it's not about treating everybody the same. It's about prioritizing those individuals, populations, groups that have the most barriers, and providing services to others as well. And as Ajira talked about, like, that's how you equalize things. The second question in terms of who, you know, I think that's what I shared on like kind of like summing slide. I mean, I think everybody should be involved in this. I mean, obviously DHCS, which is the Department of Healthcare Services, which is the implements Medicaid in California, is the one that you know, has the most power in some ways to kind of set the terms of how this should be done. They and the managed care plans, but I think DHCS has not been emphasizing equity enough. I don't think that that's part of any of the metrics that the plans have to live up to or measure, et cetera. And then, you know, I think that they have to hold the plans accountable for, like, show us that your network of providers is diverse and includes these small organizations that are most trusted in the communities that are most affected by racism and other isms. And so, yeah, that would be what I would say. I welcome other thoughts from anybody else who presented today.
I don't see anyone. Oh, Rohan?
I'll just echo that. I think that there's a little bit of finger pointing going on about who should be the one leading this effort amongst our respondents. And my sense was that the technical assistance providers is somewhat outside just like slightly adjacent to the actual delivery of CalAIM services, are kind of trying to pick up the pieces by doing what they can, to try to really be somewhat intentional. I don't think it was across the board, but I think there was more intentionality there in terms of uh, finding the service providers that can make local impact for communities that are most affected and minoritized by racism, and then trying to lift them up and include them and provide assistance to them to be able to manage the billing and documentation issues that Joanna was referring to. Um, but yeah, I don't think that there's a centralized effort within the actual delivery system of CalAIM, which I agree. I think that should be coming from the state.
Great. Thank you both for those responses. Just because of time, I'm going to go ahead and wrap us up. I feel like we could talk for much, much longer, and I have lots of questions from the audience to send you after this session. But thank you so much for coming and presenting. And this team will come back and present again, likely in about a year, but they have lots of other things going on in their project. And I believe my colleague Sadina Belmashkin included the project page on the Systems for Action website. So if you want to follow along with their findings and what's going on, you can find a lot of information there. But thank you so much for joining us today, and we hope you have a lovely rest of your Wednesday.